Welcome to this video. My name is Dr. Farzana Hoque. I'm currently working as an assistant professor of medicine. I strongly believe this lecture is critical for any physicians, because in this lecture I will talk about how to do safe patient discharge from hospital. As all of you know that now patient hospital courses are quite complicated, not only due to their acute disease. In addition, our patients has lot of comorbidities, as well as many of our patients have unique socioeconomical challenges. When we are treating our patients, when we are making plan for their discharge, disposition, we need to keep in mind and be vigilant about their socioeconomical status. We are not only treating the disease, we need to treat the patient as a whole, as a person. Disease acuity affects obtaining the detailed medical history. For example, if the patient is encephalopathic or if the patient is severe pain, they will not be able to give you the full detailed history. Also, poor team collaboration can be a huge threat for patient safety and for safe patient discharge. Now we have high team turnover. Almost every week, the team is changing, as well as the healthcare has become more fragmented. I work in a big academic hospital. There, for example, the orthopedics team is very specialized. We have one team for ortho hand, one team for ortho spine, one team for ortho trauma. So as you can see that our team are really focused and specialized. That is definitely a good thing because they are expert in this. In contrast, if all the team are not communicating with each other, that's a huge threat for patient safety. I found this data truly striking. 2/3 of adverse events leading to unintended readmission may be preventable. As you can see that we have a lot of room for improvement. Imagine if this is your loved one, your family member. 66% of readmission are due to adverse drug events. I was shocked to know that less than 50% of our patients know their diagnosis, treatment plan, or side effects of prescribed medications. The research has been showed that we physicians always overestimate about our patient understanding. When I was about to start my internship, my mentor asked me that when will I start planning for discharging a patient? The answer is as long as patient's airway, breathing, circulation are stable, we need to think about D for disposition. So rule of thumb is that keep it in your mind, the patient discharge plan from the day of the admission. The discharge process. As all of you know, that discharge process is not straightforward. We need to plan ahead so that we can meet all the requirements for our patients. The discharge process should start on the day of the admission. On the day of the admission, we need to assess patient's baseline functional status. I always ask about that patient that are they able to walk without any support, or do they use any walker or cane or wheelchair? We also need to assess patient's baseline mental status. Majority of the time, when the patient are not able to give me the full detailed history, I always communicate with patient's family member, at least one family member who knows the patient very well, knows about their medication, or if the patient is coming from facility, I always make sure to reach out to that facility. It's extremely important and helpful, because if you call the facility, you will be able to obtain their baseline status, their medication. Then comes that important part, medication reconciliation. Always remember that on the day of the admission, medicine reconciliation is critically important, because actually the patient is carrying all those medications during that hospitalization, as well as the majority of the time we are doing the reconciliation during discharge from the admission reconciliation. So be vigilant and take your time when you are doing the reconciliation on the admission day. If the patient is more than 60 or depending on their functional status, I always consult physical therapy and occupational therapy. Even if the patient came from home, I need to make sure about their functional status during the discharge. So always I make sure to consult physical therapy and occupational therapy, particularly if they're elderly, or if I feel that it will not be safe or they will need some help to ambulate. Speech therapy. For that, I definitely use my clinical judgment. In addition, I always do open communication with the duty nurse to find out, was the patient coughing or choking during taking the medication or the food. If they have any concern about patient swallow, I always make sure to consult speech therapy, because I do not want the patient to have aspiration during hospitalization or come back with any kind of aspiration or any comorbidities from aspiration. During hospitalization, when I am seeing the patient on daily basis in the hospital, I want to know how the social support is available for this patient, who usually do the medication management, or truly do they have anyone who can help them at the home. After I have the physical therapy or occupational therapy recommendations, I touch base with our social service, like case manager or social worker, depending on the PTOT recommendation, about their insurance, because I need to find out that where I can discharge this patient safely. If the speech therapy is recommending any particular thing, like if the patient is requiring tube feeding, I always make sure that I'm taking steps for that before ahead, so that I'm not holding the patient discharge, just only arranging this thing like tube feeding or maybe PEG tube. Wound care. It is very, very important to assess the patient on the day of the admission, that do they have any wound, or do I need to provide any specific wound care. And always make sure to document in your history or assessment and plan if the patient presents with any wound on admission. And also, I always document the wound care recommendation under the discharge instruction. So when I am discharging the patient, I want to make sure that I'm not forgetting to document as well as letting them know about the wound care instructions. If the patient has any new oxygen requirement, for example, if they have acute hypoxic respiratory failure or acute on chronic hypoxic respiratory failure, you need to know before discharging the patient that, okay, so how much oxygen will this patient need at home? So always consult the physical therapy for 6-minute walk test to find out that whether the patient will need any oxygen, or if they need, how many liter oxygen they will need. After I find out that, okay, so if the patient will need the oxygen, particularly if they are going home, I need to find out who will pay for this oxygen. Because if the patient does not have insurance, I had that firsthand experience from my patients that it was very expensive for them to bear the cost. So if they have to self-pay, I feel obligated to tell them earlier so that they can make the arrangement. Because if the patient is now requiring acutely 4-5 liter oxygen, I cannot just send the patient to home without oxygen. That's not the safe practice. For any new onset diabetics, or if the patient has uncontrolled diabetes, always make sure to consult diabetic educator. Diabetic educator can counsel them about the diet, which is critically important. Our diabetic educator, they usually give them the strip, the meter, and they will also educate them about the indication and side effect of all the medications, as well as they will educate them about the hypoglycemia. Finally, maybe many patients do not have primary care physician, and it is very important that they should follow up with a primary care physician. If the patient does not have primary care physician, when they're staying at hospital, when you are seeing them on daily basis, that is the perfect time to find out a primary care physician, or if they do not have any insurance, to find out a community clinic for them. Please do not keep all these important steps on the day of the discharge. Finally, on the day of the discharge, again, critically important is medication reconciliation. I cannot stress enough that how much important is it. Whenever you are reconciling the medication, be cautious about the dose, about the route, as well as about the allergy, because not always the EMR will give you the alert for the allergy. For example, sometimes maybe patient has 14, 15 allergies, and not all the medications I find out that EMR is giving the warning for allergy. So please be cautious about it. This could be someone's life or death. I always prefer to use order set for the discharge order as well as for the admission order. Personally, I found that the order set from any EMR is really comprehensive, and it will make you efficient, as well as it will help you not to miss any important order. Always schedule the patient's follow-up. You can email the scheduler if it is available at your hospital, and make sure that patient is following up with primary care physician in 1 week. It is very important to educate the patient to give them the emphasize that they must need to follow up with their primary care physician, or if they are going to any community clinic within 1 week. I found it best practice to call the family member. I definitely keep them regularly informed about the patient treatment plan, health status, any significant changes. In addition, I will highly recommend you to communicate with at least one family member on the day of the discharge, or maybe just before the day of the discharge, to let them know that you are planning to discharge the patients, what changes you did, and what will be your recommendation, as well as to whom they need to follow up after discharge. If the patient is coming from facility, please also reach out to them and try to finish your discharge summary before they leave the hospital, so that the nurses can print out the discharge summary and send with the patient. I also found it very helpful to communicate with primary care physicians, particularly for my sick patients, as well as communicate with the specialist. If you have the opportunity to provide bedside delivery of medication at your hospital by the pharmacy, please do that. Because after the patients are discharged, they are tired and they have to go to home now. They are in this much urge to go home now. And maybe not every patient has that ride or that much physical and mental energy. So if you are able to arrange that bedside delivery for medication, I found it really helpful for the patient, and they will be thankful to you. And I believe this is one of the way to enhance patient medication adherence. If the patient is going to home, it is very important to assess any barriers. For example, do that patient has right to go to the appointment? Does your patient see himself or herself to use this new medication or to do this test you advised? For example, for one of my patients, he missed his bronchoscopy appointment. We were thinking that patient is not adherent to our treatment plan. However, when I was trying to obtain more information, I found out that he simply did not have the right to go to the appointment. Another example about one of my patients who presented with asthma exacerbation. She also had diabetes. So I consulted diabetic educator because her sugar was high with the steroid. And our diabetic educator recommended her to use insulin at least for those days while she is on oral steroid. She was agreeable with the diabetic educator. So next day, she was agreeable the day before the discharge. The next day, when I went to talk to her, and I asked her that she will use that insulin just for those days while she is on steroid, she told me that there is no way she will put needle in her body. So if I would not ask the patient that does she see herself to use insulin, I would just miss it and she would go to home on insulin. She would go home on steroid without any insulin. And now you can imagine that what will be her sugar, because we were struggling to control her sugar in the hospital with insulin. For some of the patient, if you feel that they will be benefited from home health, or if they have insurance, they are agreeable, touch base with case manager to arrange the home health for them. Under this home health service, patient will get physical therapy, occupational therapy, and skilled nursing support 3 days in a week. I always ask the patient, because I found that some of the patient, they do not prefer someone to visit their home. And another group of patient, they may need to go to any facility. You feel that that is safe for them. The physical therapy, occupational therapy is recommending. However, the patient or the family member are not agreeable. So for those patients, with their permission, I arrange the home health so that at least they have some supervision, some assistance at home. If the patient is going to home with IV antibiotics for maybe a couple of weeks, find out that will the patient need midline or peak line, and touch base with your nursing staff or with the IR team to placement of the appropriate line. If you are waiting for the last day of the discharge for this placement of the line, and if the IR team is busy to place the PIC line, patient may just leave, because sometimes patient, they do not have that much energy and patience to wait one more day just for the PIC line. So this patient may just go home with against medical advice. So be prepared ahead. Also, if the patient is going to home with any antibiotics, we need to find out who will follow that weekly lab, because if the patient is going to home with IV antibiotics, we need to check their majority of the time complete blood count, CMP, as well as urine analysis at least once in a week. So we need to have physician arranged. It could be infectious disease team, or it could be patient's primary care physician. Also, we need to know that is our patient is monitoring the INR, or is there any support we can provide them for checking their INR. If the physical therapy is recommending to use any durable medical equipment such as cane or any walker, make sure you are arranging those before, because for EPIC particularly, as I am using EPIC currently for last couple of years, once the patient is discharged, you cannot put any order. It's so much hassle for the patient and so much time commitment for you. So make sure you are arranging those DME like walker, cane for those patients ahead. Another important point here I would like to mention that if you are starting any nebulization treatment for any patient new after their discharge, make sure to put the DME order for nebulizer. For some patients, they do not want to cook, and they may not be physically fit to cook. And so for them, I always consult case manager and request them to give all the resources for Meals on Wheels. So besides home, which other places can our patient go? As you know, that we also have inpatient rehab. So which patients are qualified for inpatient rehab? For inpatient rehab, our patients will get 3 hours of rehabilitation service daily. It could be either or more, like physical therapy, occupational therapy, and speech therapy, at least 5 days per week. Patient need to be stable to allow the full participation. So key point to remember that here patient is getting therapy 5 days per week and it need to be minimum 3 hours. What other places our patient can go? Skilled nursing facility or SNF. In order to be qualified for SNF placement, patient need to stay 3 inpatient midnight per Medicare. At SNF, patient will get around 2 hours of therapy per day, at least 5 days per week. So rule of thumb is that for inpatient rehab, patient will give more hour of therapy. Long-term acute care or LTAC. Here patient will get 4 to 8 hours of direct skilled nursing care. Usually here the patients are, maybe they are on active ventilator weaning care, or they may have tracheostomy and now it's potential for decannulation, or if maybe the patient need complex medical care like complex draining wound. So during these transitions, there could be breakdown or there could be a huge communication gap in some critical steps. First one is medicine reconciliation. So if there is any incorrect medication, route or dosage, that will be a huge life-threatening for patient. And also another important point to remember that when patient is going to home, always make sure to give them script or maybe e-prescribe the new medication. In addition, I always ask my patients that do they need any refill of their home medications. You may think that they will tell you by themselves, but sometimes patient cannot remember and they are acutely sick. So I will highly recommend you to ask voluntarily and ask them that do they need any refill for any of their routine home medication. Provider communication. One of the biggest challenge is having any delayed or incomplete discharge summary. And maybe not sending discharge summary to primary care physician at all. Imagine if you are the primary care physician or if you are the resident physician taking care of patient in a community clinic and your patient went to hospital. They are telling that I went to this hospital and you have no idea that what happened, and patient may do not remember. They do not remember that what kind of treatment they got or what medication changes they had. So you do not want that to happen to your patient as well as to other patient. So always be careful to complete your discharge summary on the day of the discharge. Patient education. Always educate the patient about their diagnosis, about any new medication or any kind of dosage change for their home medication, as well as follow up. Make sure you are not only writing the follow up under the discharge order set or not only in your discharge summary. It is critically important to tell them verbally as well. And I always make sure that I'm telling at least one of the family member, if they have, about their diagnosis and about their follow-up as well. Another important point is if the patient should be on any activity restriction, please remind them, because they may do not think about it, or because this is completely new to them, they are not habituated. So the patient and the patient family member need to be informed about this new activity restriction. In summary, plan for the patient discharge disposition earlier on the admission. I should say always keep it in your mind from the day of the admission. Be vigilant about medicine reconciliation. As I mentioned earlier, that one of the significant number of adverse events happen due to incorrect medicine reconciliation. Communicate, communicate, communicate. It doesn't harm to over-communicate. Communicate with the patient, communicate with the patient's family member if they have and if they are agreeable. Communicate with patient's facility if they're coming from facility. Communicate with the primary care physician, your social service like case manager or the social worker, and finally the duty nurse, because after you communicate with these people, they will give you a lot of valuable information that may really have direct impact on patient care. Finally, document, document, document. Always remember one saying, which I was told by mentor multiple times before I was starting my internship. If you do not document anything, it didn't happen. So if you are counseling the patient about any specific recommendation, talking with the family member, if you are recommending that it will be safe for them to go to facility, however, they want to go to home, absolutely, they have the right to choose their way. At the same time, you need to document that you had this discussion and now you are following their plan. So always make sure that you are documenting whatever the significant changes or significant conversation you are having with family or the patients. Thank you so much for joining me for this video today. I hope that you will find this video helpful and you will be able to implement the lessons from this video for your internship or during your residency. I wish you the best. I will see you in the next video. Please like this video, subscribe to this channel. Bye for now.